You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. In this episode, we're going to be speaking about the STAB5 mnemonic with Callum and Mark. So what we're going to do really is look at this crucial tool that's recently been released by GWAAC for emergency personnel. And it's a powerful framework really designed to help staff through complex and indeed chaotic scenarios of penetrating trauma. So the STAB5 mnemonic helps ensure that nothing is overlooked within penetrating torso injury and that care is delivered both effectively and efficiently with a reduction of time on scene. So in this episode, what we're going to do is really break down each component of the STAB5 mnemonic. We're also going to explore the background and indeed the real-world application and hear from the authors of the tool. We're also going to look at scene safety, hemorrhage control, and we're also going to look at some of the compliance to the tool as well. So I've got the authors of the tool with me, both Callum and Mark. Welcome both to the podcast.
Thanks, you.
Well, thanks for having us.
I wondered, Callum, if we could just start with you, if you could just give us a bit of your background, and then Mark.
So I'm from Australia originally, did all my paramedic training over back there, and then kind of came to the UK with that big influx of paramedics into London. So spent a bit of time in London and worked on the kind of tactical and joint response unit there, which was kind of where my main introduction to penetrating trauma was, seeing quite a bit of that. And then after finishing up in London, I moved down to Bristol, where I'm now a specialist paramedic in critical care with the Great Western Air Ambulance Charity and South West Ambulance Service.
Fantastic. And yourself, Mark?
Yeah, thanks. So I am a paramedic qualified in 2010 in Bristol and worked on the road there and abouts before moving into the Heart Hazardous Area Response Team, and then wanted to push a bit further clinically, so was lucky enough to get a role firstly for about 9 months on Wiltshire Air Ambulance Charity, and then moved across to Great Western Air Ambulance Charity in 2017. So coming up to 8 years of HEMS.
Oh, fantastic. And ideal really to tap into both of your experience really around this tool. And I guess my first question before we sort of start with more formal questions would be if you could speak to, and Callum, maybe if you just go first, speak to the origins of the STAB5 mnemonic. And then Mark, I'd like to maybe get your framing as to what you'd see before this and some of the things why this was addressed and indeed why it was implemented.
The original STAB5 aid memoir was created by the Great Western Air Ambulance Charity outreach team. It's a group of critical care paramedics made up of myself, Callum Sutton, Matt Robinson, Mark Kinsella, and Fleur Raff. When that was published online, it was noticed by Dr. Luca Corenzo and Dr. Edward Ter Avest. They're an Italian and Dutch physicians who've also previously been at London's Air Ambulance. They got in contact with us and helped and collaborated with us to get the publication into the Critical Care Journal so that it could be published worldwide and utilised across the world. So the outreach team would like to thank Luca and Edward for their help in pushing the STAB5 mnemonic out across a wider audience. We started like an outreach team where we look at providing kind of clinical education days and CPD update days for our local ambulance crews and kind of topics that they don't get access to every day. So we've been working on those days. And then one thing that kind of came up is that in the Southwest, penetrating trauma has not really been a big part of our workload. We see more blunt trauma than penetrating trauma. However, in the last 12 to 18 months, ourselves in the local area have seen a kind of 75% increase in penetrating trauma cases. And for GWAAC, it makes up over 10% of our work now, which it nearly only made up 5% back a couple of years ago. And so because of that, obviously people aren't used to seeing it, and the way that we kind of manage it can be quite different to the way we manage other cases. And so from a few kind of recent incidents that we'd attended, we all just kind of got chatting and trying to think of a way that we could get that learning across in a kind of memorable and replicatable way to all the ambulance crews who are going to arrive first on scene, and even to kind of our police responder colleagues as well. So it started with Matt, who came up with the main concept of the kind of STAB5, and then we just looked into it more and all kind of edited a little bit and got to the final product that you've all seen today.
And we'll go through it actually shortly. But Mark, was that your reality as well? Were you on shift and sort of seeing maybe an unfamiliarity with penetrating disease, with stabbing shootings that people weren't necessarily that comfortable with treating or dealing with them?
Yeah, and I'd like to, say that I only really changed my mindset when I came into the critical care world, and particularly some of our colleagues who'd worked in London were much more familiar with this rapid on scene. I would definitely remember cases in my caseload, from on the road, of feeling that I needed to control bleeding that was fairly minor to get TXA in early. We've all read the studies about the earlier you give TXA, the better the outcomes. And probably feeling a pressure on pre-alerts to give full observations with numbers, SATs and systolic blood pressure and these kind of things. And I suppose as I've matured as a clinician, I've realized that there are some conditions for which paramedicine is set up to really make a big difference. Something like anaphylaxis can be great. You can take someone from death's door to practically wanting to, be discharged at scene, although obviously we shouldn't, but they'll feel like that. I think there are a few conditions though, stroke, STEMI, penetrating trauma, that we need to recognize we're not there to fix that. And every intervention needs to be justified and weighed against the time delay. And so I've had, the privilege of working in the job that I do, and I'm able to focus a bit more narrowly on certain patients and condition states. I get a bit more time to think about it, to debrief it, to go through with my expert colleagues, and luckily we work with some really clever people to get into the granular detail of these things. And so hopefully we can pass all that learning and thought on, rather than hoarding it for ourselves and not telling anyone about it.
Listen, I absolutely agree with you actually. And as you said, there's certain pathologies you're actually only temporizing within pre-hospital care before you can actually get them to definitive treatment. And penetrating wounds from stabbing would be very much one of those, that it's a sort of temporizing feature until definitive care, until damage control surgery, or they're on the table. And you've kind of answered in a way, Mark, really nicely, just, the particular need for a mnemonic like this, because time it does expedite time to definitive care, and like you said, there's certain pathologies which actually you just need to narrow the corridor of time, and that's one absolute key facet of the STAB5 mnemonic. Callum, could you take us through the STAB5 mnemonic? So we will put it in the show notes, links in the show notes, but it's really helpful for listeners to have sort of an image in their heads of each facet.
Absolutely, no worries. So STAB5 helpfully is mnemonic that kind of works its way through the whole scene and the job, hopefully. And so kind of the essence for scene safety, and I'm sure we'll discuss everything in a bit more detail, but this is trying to think about keeping ourselves safe, but also about being a bit more dynamic than we have previously been in the past, and starting to be proactive in getting to scenes as early as possible. Triage in a number of ways. Obviously, we want to triage all of our patients if there's multiple patients on scene, but also make sure that we're triaging these patients to the correct hospital and getting them to definitive care. And assertive scene and patient management. So that's being confident and controlling the scene. So managing the other emergency services, and also being assertive and, I guess, aggressive in your management of bleeding control and creating momentum, which brings us on to the bleeding control. And that is really, at that stage, kind of catastrophic hemorrhage. So making sure that we're on top of that that catastrophic or significant hemorrhage. And then 5 minutes kind of maximum on scene is what we're saying. And what we're not saying with that is that 6 minutes is a failure and 4 minutes is a success. We're just talking about really trying to actively get people to create that momentum and get off scene. And I guess it's important to stress that this is a penetrating trauma mnemonic, and there is, this is not a all comers thing. So we know that traumatic brain injury, spending time to sort out that person's oxygenation and perfusion is important, and managing those secondary brain injuries. Equally, pediatric cardiac arrest is not something that we should be chucking in the back of an ambulance and running with. We need to establish ALS and do good care on scene. So it's important to remember this really is a penetrating trauma mnemonic, not a rush with everything. And then we just kind of focus on a few different bits. So making sure that kind of we're looking at meeting critical care for that enhanced level of intervention if possible, but not waiting around on scene, sitting still for that. And that we're managing the patient en route. So not looking to the old kind of scoop and run versus stay and play thing, where we're just putting people in the back of the ambulances and then running without any intervention. But whilst we're moving these patients to the right hospital, we're managing their wounds, we're managing their bleeding and hemodynamics as best we can.
I think something you just notioned towards then, or just indeed even going through the tour, is just the reproducibility is key. So keeping it simple, because like you said, the more complex it is, the less compliance, but less people will remember the key facets, exactly what you've been through, actually, Callum. But it's important, like you said, it's not a linear cutoff, but it's an aspirational target time. But let's go through the components actually, because I think it is, like you said, important just to deep dive into the components. So Mark, I wondered initially if I could just get you to speak to the scene safety and indeed the approach and priorities on scene from a scene safety perspective that's front of mind when you get there.
Yeah, so I think scene safety has, as Callum's alluded to, has maybe started to evolve into a more mature system now, with the increase in the multi-patient stabbing events, where anyone's a target, is very different to maybe the domestic incident that we've seen for many years now, which again is very different to the more gang, county lines, young men sadly stabbing each other. I think they all should trigger a little thought in your mind as a professional who's dispatched to one of these about what specifically might be worth considering. In the marauding situation, your RVP might need to be quite far away from the scene. When you're considering something like a domestic, then maybe it can be quite close to the scene. But we do have pretty clear guidance from inquests into major incidents and individual incidents that there is a significant care gap, that the key interventions aren't delivered early enough, that the scene was safe, and that actually enough information can often be gathered by communicating with your dispatchers about what is the nature of it, what does it sound like, are there members of the public providing first aid, and they've stopped, they pulled over, there's lots of people there that can see that the scene is perfectly safe. And you're never going to get 100% safety in anything that we do, and so I think we need to really go for that dynamic risk assessment, and that's both in where you're sent to, because I've seen certainly the RVP be set up by someone who's not familiar with the area, who's looking at it from a top-down map, doesn't understand the line of sight or where people might go. So you need to just make sure that your RVP is correct, and feel free and empowered to move it if you think that's appropriate. Again, looking at the map when you're dispatched, because it might be on a main road that you're going to come to the junction. You can have a drive past with no lights and sirens. You can just cut the corner of a junction and look and see. And if things are very calm, then you might edge forward. Ultimately, it requires discipline and calmness, professionalism to do that, as you say, replicably across all of the different kind of areas and variables. But that's something that we do quite a lot of, really, is to go up and be confident enough that if I pull up and see a casualty and then somebody comes running at me with a knife, I'm going to drive away. Once we don't want to get tunnel visioned into always getting out. You need to make a definite decision to go there. And one of the things might be that if you are in a transporting resource, taking the patient away makes the scene safer, right? The other thing to consider as well is that just because the police are on scene, we know that the police come in a variety of abilities, from the PCSO up to taser through to full firearms response. And when someone keeps coming running around, are you going to be in the crossfire or something like that? So lots of things to think about. And for people who are maybe new in their career and still learning, then leaning on their colleagues or dispatchers, or just taking a back seat and saying, I'm not ready to make those kind of big calls, I think is very reasonable. But if you're willing to, then we should encourage it.
Yeah, indeed. And Callum, before we move on, actually, I'll just get to you to speak to your experience, because London's a great teacher in a lot of ways. And to Mark's point around so some of the atypical scene safety issues, which is, the goodwill of friends, but might be inebriated, might have had quite a lot of alcohol on board, and then, it's a heightened emotive situation, and actually them getting in the way, also quite rightly, as Mark said, around rapid removal of patients to more of a domain or space that you control rather than the scene controls, and that malaise and that noise, that frenetic noise. But could you speak to your experiences from London and what that taught you and what you brought with you to GWAAC?
Absolutely. I think all the points made are absolutely perfect, and the way that we, often if it's an MTA type incident, a lot of those will come in as an RTC or something quiet, and so you won't actually know, and you might be in there before you realise. And so being able to respond to that is one thing. But I think we know that most of these stabbings that we see in the UK at the moment are probably on that kind of spectrum of fights or gang-related penetrating trauma, and those people don't want to be there when the police arrive, so they'll often be off scene before you get there. And so making your way to scene is perfectly reasonable if you do it dynamically. But that does create the other issues, like you said. So often, I think I've found that these scenes are highly emotive. There's usually family, friends. Like you say, it's out the front of a nightclub on a Saturday night. Everyone's getting involved. Often it can come across as aggression or agitation towards you, but usually I've found if you talk to these people and just kind of reassure them and ask them to help you to get to the patient and start creating that care, then that will calm them down. They just want something being done for their friend. So always being dynamic and sending people off if they're getting in the way. If you send them off to, we're going to have to extricate them soon, can you go and make sure the path's clear, or give them little jobs to kind of keep them occupied and out of your way. But again, if you're on the side of the road and you've got an ambulance there that you can drive off down the corner and you can get the patient in the back, then you're already heading in the right direction. So there's plenty of dynamic jobs, but I would say most of the penetrating trauma scenes that I've been to are the ones that come to mind when people ask about kind of dynamic scenes and all that kind of thing. These are the ones that really are quite chaotic, and there's people everywhere. So really keeping your wits about you and having somebody there. There's usually police around, isn't there? So having them help you with the patient care, having them help you to keep scene control is really important. And these are the jobs that kind of emergency service team as a whole really come together to make a difference, because there's no point in the paramedic. If you're the only paramedic on scene, then why are you stopping bleeding when you've got a police medic next to you who's perfectly capable of doing that? You can be doing other things, like getting that access or moving the patient if your transporting resource is not there yet, whilst the police officers are providing their level of care. So I think always work to your level of care, and if there's somebody on who has a different level of care, using them to to do that. I think that's what we did on JRU quite a lot, is we'd often be there by ourselves with the police for some time because we'd have that early heads up. And so we'd always try and use the police to the best of our ability. And so that as soon as that ambulance arrived, that patient was ready to be up off the floor and in the back moving towards a trauma centre.
So let's pivot slightly and look towards the T or triage on scene. And as you both mentioned, equally as important, actually. So looking at the best practices for triage, Mark, what would you advocate? You mentioned before, like you said, it's starting to become more frequent that there's more than one patient, and actually that certainly mandates triage. And but just if you could just give us what's front of mind for you when you're triaging patients.
Yeah, thanks. So we advocate the use of that 10-second triage model, even in the single patient. I think there's a really nice diagram that we've copied across, that you can get an assessment of a patient in broad brush strokes within 10 seconds. And I'm sure that all of our listeners could think of patients that they can, in half a second, even less than that, they'll know that they're going to be ill, or even just from the trail of blood before you even see the patient, you might realize that that's part of your triage, isn't it? It's a very holistic approach that comes with years of training and Gestalt and everything else. But the thing that we want to make sure of as a minimum level of safety when it comes to triaging patients with penetrating trauma is to expose them fully, and that can be really awkward, particularly in a windy, rainy British weather, and maybe moving them into the ambulance in those situations is the appropriate thing to do. But definitely stripping them off, looking in all the nooks and crannies. So this is axilla, under the armpits, checking their back, looking into the groin, between the legs, perineum, the rectum. We do see people deliberately stabbing into the rectum because it's humiliating. These people then have to go for further surgery, have bags that they use, and so that hence the term bagging. And so that is something that they go for. Making sure that we have our first look as the best look is something that we teach all of our trainees. And so that when further people come along, you're not embarrassed, by the wound that you haven't found, or when you're handing over. So using that 10-second triage model gives you a good feel of the P1, P2, P3, which can guide some of your interventions or the calls that you make. The key, though, I think, with the penetrating in a single patient or maybe two patient event, one that isn't overwhelming in terms of the numbers of casualties, is to say that although you might get a P1, P2, P3 number by using that, TST model, if it's penetrating torso trauma, they are big sick until proven otherwise, even if they look really well. And so if the listeners go to the show notes, the mnemonic comes with it quite a lot of elaboration whilst still trying to be quite punchy. And we're really keen that these patients, if you cannot clearly see the wound bed, we like the raised wounds that we've seen in the DSH patients, that's what I'm talking about when we say see the wound bed. If you can't see the wound bed, then just assume that it's in their torso. That patient, if they came bundling out of a car into the car park of a hospital, would almost certainly go for some form of imaging, likely CT scanning. And if that's what the hospital do to determine whether that's gone into their chest, then what we shouldn't be doing is eyeballing it and saying, I was probably all right. So if you can't clearly see the wound bed, then we want to get these patients to a major trauma center that's appropriate, and that might be pediatric, unfortunately, when they're 14, 15. So a major trauma center. There's a real trickiness, and this is where we earn our pay as paramedics, isn't it, as independent clinicians and professionals, is to weigh up risks and benefits. Can I get this patient to the definitive care, to the surgeons, before they have a cardiac arrest? And you're never definitely going to know the answer, but that's where you earn your bread is by trying to work that out as best you can. And remember that when you're looking at the times, maybe on Google Maps, you've got a major trauma center that's 30 minutes away and a trauma unit that's 20 minutes away. The binary answer is goes to the trauma unit, even with someone that's really, really sick that needs immediate blood product resuscitation and maybe some surgical intervention. That you need to also have in your mind that a major trauma center at 2:00 in the morning on a Saturday can produce quite a different response in the time frame to most trauma units, not all, but most. How quickly are they going to be able to get a senior clinician up and ready and a team and some surgical skill? How quickly are they going to be able to get their level 1 transfusing equipment? How quickly can they get blood products, and what are those blood products? Is it just going to be a lot of, a ton of O negative, or are they going to be able to get the FFP and things? The trauma centres have access, I think, a bit more quickly. So time to the intervention is often different to the time to pulling up.
No, indeed, and that's really comprehensive, Mark, and from a number of perspectives. But like you said, that full exposure, and like you said, the risk benefit analysis as to where you go and how you progress there. And as Callum said before about maybe not waiting for critical care and seeing, but you can always RVP and liaise en route, so that there is no time lost. And to both of you were saying before, almost initiating that forward momentum quite quickly on scene, whereby things can be done whilst moving even to the ambulance. You can start to put oxygen on the patient and start to prep the patient, and then, like you said, do a full exposure when you can. And that's a really comprehensive answer there, Mark. And so we'll progress on to and Callum, I'll get you to speak to the assertive scene and patient management, and maybe if you could just speak to the sort of critical steps or facets of assertive scene and patient management within the framework, and what's it sort of look like for you?
Yeah, no worries. So I think this is kind of multifaceted. This one, we kind of look at assertive scene management and scene control, and then assertive patient management as well. I think when we talk about scene management, that is doing that dynamic risk assessment, getting into the patient as early as possible, moving forward and making your own decision around safety, and not necessarily just waiting to be told. And then once you're in on the scene, like with all multi-agency incidents, there's different emergency services, all with differing priorities. And it's important to kind of, like you would with a kind of acute behavioral disturbance patient, where they're being restrained by police. It's important to declare this patient as a medical emergency and create them as a patient, so that you put yourself in as the paramedic or the ambulance clinician as the lead for that patient now. And the police obviously need to keep their evidence trail, and they need to often come with you to hospital and that kind of thing. But it's important to be assertive and say, okay, I'm getting this patient, and we're going to be leaving scene in 5 minutes. You need to have somebody who's ready to come with us then, or we're leaving. And not being told, oh, there's someone 2 minutes away, just wait for us, kind of thing. The patient comes first. So really kind of pushing that scene forward, using your operations officers, if they're on scene for this, to do that liaison for you so that you can focus on it, on the patient, but working with your police colleagues, but really letting them know that this is a patient who needs to be leaving now and not being held back for kind of evidence gathering or for further officers to arrive. And then from a patient point of view, we're just really kind of using that assertive word just to show that we're looking for early and rapid intervention, being proactive with your assessments, making sure that we're doing what Mark said and fully exposing the patient and looking for wounds in hidden places, getting onto that bleeding early, really hot on your packaging, bandaging, tourniquet if required, and we can talk about that when we get to circulation. But just because there's a tourniquet on from police, or you need one initially, doesn't mean you can't downgrade that as you move towards hospital. And then looking to get off scene, what we don't need on a penetrating trauma patient who's alert is a blood pressure, a blood sugar, a temperature. multiple points of access. Let's, if they're able to walk, let's get them up and into the back of the ambulance. If they're not able, getting people with hands on, multiple police officers to lift them onto the bed, or a scoop if you're good with it and rapid. But if you look at a patient and you can see that they've got an increased work of breathing and that they've got an absent radial pulse, that's enough for you to know that that patient's really unwell and needs to be moving. And if you call a trauma team leader at a major trauma center with that as your pre-alert, that you've got a central penetrating trauma injury, no radial pulse, diaphoretic tachypneic, that's all they need to activate everything. They don't need you to give them the full details. And then continuing that assertive management once you're on the way to hospital. So start moving to hospital, and then that's when we want to complete our kind of patient care package. So obtaining IV access if we can, administering TXA. Remember analgesia, this hurts and is painful. So analgesia, and then meeting that critical care team who can then offer blood product resuscitation, or further kind of surgical intervention as required. I think there always comes up a little bit of a question we've had a couple of times about, like, well, I don't want to cannulate on the move and all of that kind of stuff, and that's completely reasonable. But there's nothing stopping you kind of being in your seat and putting the tourniquet on the patient's arm, prepping the cannula equipment, pulling over for 10, 15 seconds to put the cannula in, secure it down, and then moving off again. So be safe, but try and get through that kind of assertive management on the way to hospital.
Let's move to bleeding, actually. And Mark, if I could get you to speak to bleeding. Callum's just made a really interesting point about down regulating maybe potentially taking off or quality assuring a tourniquet. Very much is my experience as well. When you're not necessarily the one to put it on, my revelation really practicing critical care was 90% of the bleeding was either internal, or indeed you could control it with more fundamental basic methods of hemorrhage control. But if I could get you to speak to bleeding and what some of the key considerations in your mind are.
It's important to say that the police more and more are getting experience and training and equipment to deal with hemorrhage, and so you are going to probably find more police applied tourniquets, chest seals, pressure bandages. With the bleed kits that we see going up, then that's the likelihood of these community applied tourniquets is going to be higher. And so what we need to do in our mnemonic, really, when it comes to bleeding, is to just make sure there isn't a catastrophic bleed before we start trying to move the patient. That's all it is. There's no point trying to throw someone in an ambulance and drive off if we've not stopped the femoral artery pumping out blood. So what we're saying is, before you get to that 5 minute, the leave scene, is just to make sure that they're not going to bleed to death before you've even achieved it with external hemorrhage. But then when we get into the more kind of detailed stuff, once you're moving, I think we should be we should consider tourniquets a temporary measure, not just for the surgeon but for us. And if you sprung a leak in your house, you'd turn the stopcock off, and then you probably apply some plumber's tape, and you might turn it back on again and see if you've sort of got it done well enough that you can wait for the plumber to come and still do the dishes. So we quite frequently will use the tourniquet to stop things. You might find it easier to then identify the point of hemorrhage, pack that with some hemostatic gauze, get a nice pressure bandage around it, take the tourniquet down, and then look for what we call strike through. It'll bleed a little bit, it has to, before the clotting can happen, but you don't see it pouring through, in which case the tourniquet can just be reapplied. Remember, with these really good pressure bandages, and there are lots of brands, aren't there, but you can get some really, really tight pressure bandages. And I've certainly experienced or noticed in my patient groups that I've turned up to hospital and realized then that I've tourniqueted their arm with a pressure bandage. And that can purely be through, it's just the physics of it, right? So if they've got a systolic of 60 and you've wrapped it to a systolic of or to a pressure of 80 millimeters of mercury, then that is arterial tourniquet. And remembering that if you give some fluids or something that increases their blood pressure, it was low, you put the tourniquet on and it stops the bleeding, you increase their blood pressure, you can see that then if I put it on at 80, you improve their blood pressure to 90, then it's going to bleed through again. So just constant reassessment, really. When we've seen a lot of the junctional hemorrhage and use of the hemostatic agents, it's really quite impressive, the bleeding. And so totally understand people maybe not doing what they might do in a classroom. And that's often the kind of criticism of when we say what to do is, well, that's all well and good when we're sat here chatting on a podcast. But this is where mental modeling, bringing up the STAB5 mnemonic on the way to a job, hopefully refreshes things in your mind. You make sure you don't go into the kind of anchoring bias territory, but going in pretty assertive, like we say, with the bleeding positive. We're going to talk to the patient and maybe have to give them some inhaled pain relief because it's sore when you put a tourniquet on, or you go jabbing a load of hemostatic gauze into their neck. That's really painful. But if it saves their life, then we need to be assertive with that. So yeah, pushing it really deep down. It needs to get to the point, the proximal point of the artery where it's bleeding, and then to put pressure on it after that. And then the key, as you've said, your experience, 90%, there's not actually a lot of external bleeding with the really sick. That is definitely our experience. So with those, there's not much hemorrhage control to do, that's just a surgeon that's going to do that. And that's about us recognizing what we can and can't fix.
One of the aspects that you both notion to really, and one of the things I really like about the tool is that it does act like an aid memoir. And actually, to your point, Mark, around crews could look at the aid memoir on the way to the scene and actually potentially even have it in front of them on the way to hospital, make sure they've not missed anything. Callum, was that something that that was sort of front of mind? I guess one of my questions I was going to ask towards the end is really, do you see this becoming a national tool? And I really think there is place for this, because it is one of these halo events in some services for high acuity, low occurrence. But I guess, do you see this as an aid memoir and a checklist that crews could have clipped to their paramedic bag, or indeed some of their kit?
I think we hope so. It's been picked up by a couple of ambulance services to add into their kind of GWAAC Help Plus apps and that kind of thing. And yeah, I imagine so. We do it all the time on the way to a job. If we're not solo, if we're a two-person team and we're going to a pediatric job, then we'll look at page for age and start going through some numbers. And I think that we've had some good reports from crews who have used it in that way on the way to jobs, have kind of just used it as a quick kind of recap, so that when they get to scene, they're kind of ready to go and move in that direction. I think the more kind of helpful aid memoirs and mnemonics that we have for on the way to jobs, then the better, I think.
So just looking at, as we're coming to land really on the podcast, one of the things that I think this tool really addresses is this historic trend of sort of waiting on scene for critical care, or indeed prolonged scene times. Mark, if I could get you to speak to a couple of things, really. One, have you seen, since the tool has been implemented, and maybe Callum after Mark as well, just have you seen a narrowing of scene time? And two, have you seen sort of an uptick or an improvement in moving to major trauma centres?
Yeah, thanks. So it's not been a huge amount of time since it was released, only a few months, but there's definitely been some case reports of. So there's one of a basics doctor. We don't run a 24-hour service in the Bristol area, but a basics doctor that arrived to a scene. He was dispatched to a young stabbing in the city centre, and when he pulled up, they were gone. And when he asked the police what happened, they said, "Well, we don't really know. The ambulance came, chucked him in the back, and drove off." But that's great, they got all the appropriate interventions. So yeah, we definitely see it starting to bed in. When you talk about the RVing with critical care teams, I think that's really difficult. and hopefully one of the things from this mnemonic is to build a shared language, something that we can all refer to whenever there's kind of disagreement or different points of view. And deviation is always reasonable as long as you can justify it, right? But I think the listeners might well have stories of their own where they say, but I did all this and got told by a critical care paramedic to stay on scene, and that might be because there's something that they've considered, and that's all about communication, isn't it? Why is it that you want to do that, and hopefully we can communicate professionally, and we all know that civility saves lives, in more so in these situations than any other. But having a shared language hopefully might mean that when you do get in contact with your critical care colleagues, you can say, I'm doing the STAB5 thing, so where do you want to meet? And if they say, well, stay on scene, you can say, okay, that's sort of against it. Why is that? And they can either give you a rationale or not. And that might be something to follow up in a debrief, and just, I suppose, knowing that these things do take time to percolate through, for us all to feel comfortable and confident, to know that we're not going to get criticised at the end of the case for turning up with a patient that doesn't have a blood sugar, but yeah, an RV is often tricky to achieve. And so I always say, when I'm training critical care paramedics and critical care doctors, that we don't have the patient, and the dispatchers have got a map. We're the ones. It's up to us to work out where the RV is, not the person who's trying desperately to juggle a radio and a patient who's kicking off and the rest. And that we should aim for something that's going to work and not necessarily perfect. So it'd be lovely to meet perfectly in the middle of 50-50 distances, but it might be that the critical care team need to park up at a known point. Garage forecourts are normally perfect, away from out of the rain, well lit, open 24 hours. Get a coffee while you're there, and then you might need to wait that 2 minutes that's uncomfortable for any critical care people listening, and wait for the ambulance, because definitely you're going to pick them up, rather than to miss each other and it all goes wrong. And equally, control can help you with which roads are being used, and that thing.
So something, and just as we come into line, maybe the final question, Callum, Mark's just mentioned about debrief there, and I think the debrief is such especially in critical care, such an important aspect of an incident, of a job, because like I said, there's a lot of learning that can be taken from the debrief. Do you foresee the STAB5 mnemonic sort of almost being part of that debrief, and indeed sort of just compliance to the tool? Would you bring it into a debrief retrospectively?
It's something that we're kind of trying to spread around, and I think it's quite a good place to you can use it in the debrief, I guess, as a bit of a memoir for the debrief as well, and see which parts you hit and which parts were difficult to hit, and go from there. I think debrief, like you say, is absolutely key, and visualization and learning from incidents. The more you kind of commit to your rote memory, you learn, the less stressful the next scene will be. And if you can debrief about a job and hear it from 5 other people's perspectives, then you've kind of got 5 jobs to learn from, rather than just the one that you experienced. So I think I'm a big fan of kind of visualization and debrief to help you move forward for the next job. So I think that we're all busy, and we've all got things to move on to or get pulled away for the next job. But if at all possible, I think after these kind of jobs, we should always try and have a bit of a chat, and then follow up in a week or two's time with any further questions.
Listen, that's fantastic. It's a great tool, and I think it really does not only serve as an aid memoir, but it serves as a bundle of care, really, that could be initiated on scene, and just is front of mind for these halo events. Certainly, when you're not involved in critical care and you're not seeing these penetrating torso injuries every day, I think it's a fantastic tool. So listen, thank you for the last 45 minutes. It's been great just to chat to you. We'll include the tool and resources in the show notes, and hopefully we'll speak to you both again soon.
Great.
Thanks for having us.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.